Good afternoon, dear students. I am glad to see you again, and today we continue our cycle of lectures in Propaedeutics of Internal Medicine, and topic of our today's lecture, and it is Signs and Symptoms of Urinary System Diseases. It is a lecture for third course for Propaedeutics of Internal Medicine MA groups. Today I'm going to make some points in main urinary syndromes. What syndromes I want to discuss with you? It is urinary syndrome, it is the simplest one. After it will be nephrotic syndrome, nephritic syndrome, urinary tract obstruction syndrome, and hypertensive syndrome. Plan of our today's lecture. First of all, I'm going to remind the importance or value of human kidney. After it, urinary system diseases syndrome. Separately, we will discuss urinary syndrome, nephrotic syndrome, nephritic syndrome, urinary tract obstruction syndrome, and hypertensive syndrome. After it will be a short reminder how to do kidneys work and primary function and purpose. It is history taking and patient's examination in general about all urinary system disorders, spectrum of urinary system diseases, and main symptoms of urinary system diseases. The importance or value of human kidney. You know from physiology that human kidney, it is a body filter. It cleans up to 180 liters of liquid per day, retaining the good stuff and expelling the bad. Most fortuitously, humans are born with two kidneys. If one of them becomes damaged, the other one can pick up the slack. If both kidneys fail, however, body will be filled with harmful toxins. Without medical intervention, such patients will die within several weeks. An example of such interventions you see on this picture. It is a device for hemodialysis or artificial kidney. And syndromes. First syndrome for today, it is urinary syndrome. Urinary syndrome, it is quantitative and qualitative changes in urine. It absolutely laboratory syndrome. It includes just changes in urine, and when we find these changes in patients, we can in general name it like urinary syndrome. Symptoms of this syndrome, it is changes in the volume and composition of the urine output, changes in the rhythm of urinary excretion, and changes in the volume and composition of the blood. And it's all about a urinary syndrome. It is the shortest. And the next syndrome for today, it is nephrotic syndrome. What is nephrotic syndrome? Clinical and laboratory syndrome characterized by massive proteinuria which lead to hypoproteinemia or hypoalbuminemia, hyperlipidemia, and pitting edema in results from increased permeability of glomerular basement membrane (GBM) or plasma protein. Criteria of nephrotic syndrome. First criteria, it is hematuria. It is presence of red blood cells in urine and gross hematuria. Next syndrome, it is hypertension. It is increased blood pressure more than 140 for systolic and 90 millimeters hydroargon for diastolic. Next criteria, it is azotemia. It goes due to renal insufficiency with increased level of serum, urine, and creatinine. And hypocomplementemia, it is decreased level of serum complement C3. Types of nephrotic syndrome. In most cases, nearly 90%, it is idiopathic. Hope you remember what is idiopathic. It when we don't know the exact cause. We can't find any exact cause. We can just imagine the risk factors, maybe some etiological factors that can lead to it, but we don't have the direct connection between cause and syndrome. In this case, we name it idiopathic. When we know exact cause of nephrotic syndrome, it's nearly 10% of cases, it is secondary nephrotic syndrome. Most often it can go due to anaphylactoid purpura, systemic lupus erythematosus, hepatitis B, viral infection, etc. And it can be congenital. Pathophysiology. You remember, it's just a reminder for you that structural unit of kidney, it is glomerular. It looks like this. Yes, it is a complex of small capillaries that filtrate primary urine from the blood in glomerular. When it goes damage of this glomerular, damage of this primary unit, it lead to increased permeability to proteins and lead to proteinuria or growth of proteins in urine. For nephrotic syndrome, it is special that it is intensive proteinuria more than 3.5 grams per day. Due to increased secretion of proteins in kidneys, it goes hypoproteinemia. It goes insufficiency of proteins in the blood. It is lead for, first of all, it is decreased plasma oncotic pressure, yes, protein pressure, and due to this decreasing in plasma, through the gradient of oncotic pressure, water goes from the blood to tissues and lead to oncotic edema. Edema, it is a first criteria and the most important symptom of nephrotic syndrome. Another thing that goes in nephrotic syndrome due to hypoproteinemia, it is compensatory synthesis of proteins by liver, and it goes with synthesis not just proteins, it it always accompanied with synthesis of cholesterol and lipids, and it leads to hyperlipidemia. Proteinuria, like a main pathophysiological mechanisms, and according to it, we can divide nephrotic syndrome 4 degrees. It can be mild nephrotic syndrome with proteinuria less than 0.5 grams per meter in square per day, moderate with proteinuria from 0.5 to 2 grams per meter in square per day, and severe proteinuria when severe nephrotic syndrome with proteinuria more than 2 grams. Types of proteinuria, we can divide it in another 2 different types. It is selective and non-selective. What it means? It means the level of damaging membrane. In one cases, it leads to go from the kidney just low molecules proteins like albumins. When it losing just albumins, just low molecular weight proteins, we name it selective protein. And non-selective when it all types of proteins as low molecular weight as high molecular weight goes through the membranes and lost in urine. Symptoms of nephrotic syndrome. First of all, what I told you, the most important and the most specific, it is edema. It can vary in degrees. It can be local edema. Here, the most specific edema of face, facial edema. It is early and very specific for kidney problem symptoms, especially in the morning after the sleep. If patients suffer from the face edema or periorbital edema in the morning, for example, and during the day it is decreasing of this edema, for you it is a very specific sign for kidney problems and especially nephrotic syndrome. It can be edema around eyes, what I told, periorbital swelling, and it can be in lower extremities, but it more rare and not such specific. The isolated edema of lower extremities more specific for heart failure. And it can be generalized edema. We name anasarca, such a Latin term. In lecture about heart failure, I showed you a picture with anasarca. One more type of isolated edema, it is edema of penis and scrotum. It is possible too for nephrotic syndrome in male patients. Other clinical symptoms include fatigue, lethargy, loss of appetite, nausea and vomiting, abdominal pain, diarrhea, body weight increase, urine output decrease, pleural effusion with possible, in severe cases, respiratory distress. Tests and differential diagnosis. For confirmation of nephrotic syndrome, we used first of all blood test. There include serum protein, it usually more than 5.5 in case of nephrotic syndromes. Albumin will be less than 2.5 grams per deciliter, and cholesterol more than 220 milligrams per deciliter. In urine test, for nephrotic syndrome will be specific. For nephrotic syndrome, we can see proteinuria, oliguria during stage of edema formation. It can be microscopic hematuria, nailing 20% cases, yes, less specific than proteinuria, and large number of hyaline casts due to massive proteinuria. A differential diagnosis, usually we need differential diagnosis of generalized edema. In what cases it can be? Yes, most often it is kidney problems or heart failure or thyroid problems, for example. It is the most often cases of edema. Okay, and let's one more time name the main things in nephrotic syndrome. And here we have a main letter, it is letter O. You saw in the first part of lecture that we have two urinary syndromes that changed just in one letter, nephrotic syndrome and nephritic syndrome. And easy to compare these symptoms because the main things are changed according to this main letter. Here it is letter O, and most of these symptoms, all of these main symptoms include this letter. That's why nephrotic syndrome, all words contain letter O. First, it is massive proteinuria, massive more than 3.5 per day. It is hypoproteinemia. In most cases, it is peeling out of albumin, selective proteinuria. It is edema when oncotic pressure in the blood goes down. It is hypercholesterolemia with hyperlipidemia and hyperlipiduria. And it is hypercoagulable state with thrombotic and thromboembolic complications. And I have for today for you several USMLE questions. It for your individual work, it is not obligatory. You don't need to answer for the mark for it, but who are interested in, please for yourself, for your individual work, note possible correct answers. Most of them connected with microscopic changes who are not don't have enough information. Here please stop lecture and read something about morphological changes in kidneys in different diseases, pathophysiology of kidneys, and in general in most of European American tests they pay a lot of attention to pathophysiology and microscopic and biochemical changes. That's why I include here this question. They will be quite difficult, but who are ready for it, who are interested in, you can for yourself answer for this questions. Maybe somebody prepares to some American tests. That's why it will be good practice for you. That's why first test. A 7-year-old male suffers from generalized edema. Urine protein excretion is 5.2 grams over 24 hours, and serum Uri analysis revealed hyperlipidemia. The patient's response to treatment with prednisone, and 8 weeks later his urine is not contain miscible protein. If a kidney biopsy had been performed while the patient's condition was pathologic, which of the following would you expect to find upon glomerular electron microscopy? And options. First option, efficient of podocyte food processes. Second, subepithelial spike and dome deposits. Third, it is subepithelial humps. Fourth, thin glomerular basement membrane. And fifth, it is subendothelial thickening. Test 2. A 57-year-old female visited her primary care physician with middle pitting edema in her legs, middle stage. She takes no medications and does not use alcohol, tobacco, or illicit drugs. 4.5 grams of protein are collected during 24-hour urine secretion. A kidney biopsy is obtained. Examination with light microscopy shows diffuse thickening of the glomerular basement membrane. Electron microscopy shows subepithelial spike and dome deposits. Which of the following is the most likely diagnosis? First, it is minimal change disease. Second, post-infections glomerulonephritis. Third, focal segmental glomerulosclerosis. Fourth, rapidly progressive glomerulonephritis. Fifth, membranous glomerulopathy. Next question. A 6-year-old girl presents to your clinic 2 weeks after receiving a routine immunization vaccine in the preparation for a trip overseas. Periorbital edema is present. On exam and 24-hour urine collection shows excretion of 4.3 grams of protein per day. Which pathological change would likely be seen on microscopy? First option. It is linear immunoglobulin G deposition on light microscopy. Second, immunoglobulin A immune complexes in the mesangium on electron microscopy. Third, it is tram track appearance on light microscopy. Fourth, subepithelial deposits with a spike and dome appearance on electron microscopy. And fifth one, it is podocytes effacement on electron microscopy. Next syndrome for today, it changed for one letter from the previous one. It is Nephritic Syndrome. Let's give definition to it. Nephritic syndrome, it is clinical and laboratory syndrome associated with disorders affecting the kidneys, more specifically glomerular structures, and characterized by having thin glomerular basement membrane and small pores in the podocytes of the glomerulus, large enough to permit proteins, proteinuria, and red blood cells, hematuria, to pass into the urine. Criteria of nephritic syndrome. First, and here it is a real on first place, it is hematuria. Here it will be less intensive proteinuria, but here always present hematuria. It usually goes with red blood cells casts present in the urine. Proteinuria is present too, but it usually less than 3.5 grams per day. If nephrotic, more than 3.5, nephritic, less than 3.5 grams per day. It will be present hypertension in most patients. It can be present uremia due to retention of waste products. Variable renal insufficiency with azotemia and oliguria. Low urine output, less than 400 milliliters per day. Hope you remember the definition of oliguria. Types of nephritic syndrome. In most cases, it are caused by post-streptococcal glomerulonephritis or crescentic glomerulonephritis, or another name of this disease, rapidly progressive glomerulonephritis. Nephritic syndrome. Here the main letter, it is letter I. And what the important thing that it is later which started the word inflammation. You should understand that nephritic always connected with inflammation. It is some inflammation of glomerular that we named glomerulonephritis that can lead to this nephritic syndrome. And features of nephritic syndrome, we can, for easy remembering, we have such abbreviation like pharaoh. Whereas letter P, proteinuria, H, hematuria, A, azotemia or elevated blood nitrogen levels. R, it is red blood cell casts. A, antistreptolizine or titers if post-streptococcal infection, it is most of cases. Or it is oliguria, and one more time H, it is hypertension. And several tests about nephritic syndrome. First test. Multiple patients present to your office with hematuria following the outbreak of group A streptococcus. Biopsy reveals that all of the patients have the same disease, characterized by large hypercellular glomeruli with neutrophil infiltration. Which patient has the best prognosis? Options. First, 65-year-old nulliparous woman. Second, 50-year-old man with a history of streptococcal infection. Third, 8-year-old boy who undergoes no treatment. Fourth, 38-year-old man with a sickle cell trait. And fifth, it is 18-year-old man treated with corticosteroids. Test 5. A 10-year-old boy presents to your office with color-colored urine and periorbital edema. His mother is extremely concerned, especially given that her son has not been entirely healthy except of sore throat a few weeks ago. Which of the following would be at least likely to observe on a kidney biopsy of this patient? First, it is lumpy-bumpy appearance on immunofluorescence. Second, subepithelial electron-dense deposits on electron microscopy. Third, it is polyclonal immunoglobulin G and C3 deposition on immunofluorescence. Fourth, it is linear immunoglobulin G deposition along the basement membrane on immunofluorescence. Fifth, it is a large hypercellular glomeruli on light microscopy. One more time, this test just for your interest. Who interested in, please answer. Maybe next lecture I'll give you correct options. Who are not, you are not, you don't have to. Next test, test 6. A 6-year-old boy presents to your office with hematuria. 2 weeks ago, the patient had symptoms of sore throat and fever. Although physical exam is unremarkable, laboratory results show a decreased serum complement C3 level and elevated anti-DNase B titer. Which of the following would you most expect to see on renal biopsy? First, it is large hypercellular glomeruli on light microscopy. Second, it is polyclonal immunoglobulin A deposition on immunofluorescence. Immune complex deposits which spike and dome appearance on electron microscopy. Fourth, viral looping and hyaline thrombi on light microscopy. And fifth one, it is antibodies to glomerular basement membrane resulting in a linear immunofluorescence pattern. Next test. A 21-year-old male presents to your office with hematuria 3 days after the onset of productive cough and fever. Following renal biopsy, immunofluorescence shows granular immunoglobulin A deposits in the glomerular mesangium. Which of the following do you suspect in this patient? First option, it is lipoid nephrosis. Second, Berger's disease. Third, post-streptococcal glomerulonephritis. Fourth, systemic lupus erythematosus. And fifth, it is HIV infection. And next syndrome for today, it is urinary tract obstruction syndrome. Urinary tract obstruction can occur in any point of the urinary tract from the kidneys to the ureteral meatus. It can develop secondary to calculi, tumors, strictures, anatomical abnormalities, or functional abnormalities. Obstructive uropathy can result in pain, urinary tract infection, loss in renal function, or possibly sepsis or death. Symptoms are typified by the symptoms of ureteral stricture or ureteral or renal stone. The principal complaints are pain in the flank radiating along the course of the ureter, gross total hematuria, GI symptoms, chills, fever, burning on urination, and cloudy urine with onset of infection, which is the common consequence of obstruction or vesicular ureteral reflux. Nausea, vomiting, loss of weight, and strange pallor due to uremia secondary to bilateral hydronephrosis, anemia, leukocytosis, microscopic hematuria. When it goes obstruction in the ureter, in the early stages, intravesical pressure is normal. Later added stretch effect at the lower end of ureter induced further hydroureteronephrosis. Finally, the ureteral wall becomes attenuated. And here you see the interesting picture when it on the X-ray we see kidney and ureteral stones. Mid-tract obstruction, typified by the symptoms of ureteral stricture, benign prostatic hyperplasia, neurogenic bladder, and tumor of the bladder involving the vesical neck. Symptoms of mid-tract obstruction: it is hesitancy in starting urination, lessened force and size of the stream, and terminal dribbling. Hematuria, which may be partial. Cloudy urine due to complicating infection. Acute urinary retention, anemia, leukocytosis, and microscopic hematuria. Stages. First stage, it is compensation, when the bladder musculature becomes hypertrophied to compensate this overpressure. The thickness may double or triple. Hypertrophied muscle can be seen endoscopically. It leads to superimposed with secondary infection. And next stage, it goes decompensation, when the large obstructing gland can be palpated rectally and observed cystoscopically. You can see it on the X-ray on this slide. It may appear as a mild obstruction cystoscopically. And lower tract obstruction syndrome. The principal symptoms are hesitancy in starting urination, lessened force and size of stream, and terminal dribbling. It can be hematuria, which may be partial initially with stricture, or total with prostatic obstruction or vesical tumor. It typical cloudy urine due to complicating infection, the same with previous types, and it can be acute urinary retention in severe cases. Moreover, it's typical anemia, leukocytosis, and microscopic hematuria. Obstruction lead to hydrostatic pressure more proximal. Yes, it is mostly in a cyst. It leads to dilation of urethra. The wall of urethra become thin, form and diverticulum. Infected urine and urinary extravasation, and it can lead to periurethral abscess. Typified by the symptoms of ureteral stricture, benign prostatic hyperplasia, neurogenic bladder, and and tumor of the bladder involving the vesical neck. and USMLE test about urinary tract obstruction. A 45-year-old man presents with a 3-day history of right-sided flank pain due to a lodged ureteral stone. What changes would be expected to be seen at the level of glomerular filtration? First, it is increase in glomerular capillary oncotic pressure. Second, increase in Bowman space capillary oncotic pressure. Third, increase in Bowman space hydrostatic pressure. Fourth, increase in filtration fraction. And fifth, no change in filtration fraction. Next test. Test 9. A 72-year-old man presents to his primary care physician with urinary hesitancy and urinary dribbling that began 6 weeks ago and has gradually worsened. Rectal exam reveals a markedly enlarged prostate. CT scan demonstrates dilated ureters and renal pelvises. Which of the following likely accounts for the CT scan results? First, it is ureteral obstruction. Second, it is autosomal dominant polycystic kidney disease. Third one, it is pre-renal azotemia. Fourth, elevated serum prostatic specific antigen or PSA. And fifth, it is multiple endocrine neoplasia type 1. And last syndrome for today, it is hypertensive syndrome. The elevated blood pressure, you know from lecture of hypertension that elevated, it is more than 140 systolic and 90 diastolic. Elevated blood pressure, we name it renal or renovascular hypertension in case when the cause goes from the kidney. It is type of secondary hypertension. In most cases, it caused by narrowing in the arteries that deliver blood to the kidneys, renal artery stenosis. When the kidneys receive low blood flow, they respond by releasing a hormone that stimulates the body to retain sodium and water. Blood vessels fill with additional fluid and blood pressure increases. You see the picture of 3D scan, and by the lowest narrow, you see place of obstruction of stenosis of renal artery. The narrowing of one or both renal arteries is the most often caused by atherosclerosis or hardening of the arteries. Symptoms: it can be headache, confusion, blurred or double vision, bloody or pink-colored urine, nosebleeds, bruits over the affected renal artery. It all are symptoms of hypertension except of bruits. Hypertension can cause chronic kidney disease. They worsen in each other like a pathological chain. Yes, when the problem with kidney, the kidney atherosclerosis lead to hypertension, and hypertension worsening the function of kidney, increase pressure in the kidney, and can lead to chronic kidney disease. That is worsening, one more time, hypertension. Okay. And let's remind, I promise you a short reminding, the primary urinary system functions before the symptoms. What are the functions? From physiology, it is maintain homeostasis, regulate fluids and electrolytes, eliminate waste products, maintain blood pressure, involved with red blood cells production, involved with a bone metabolism. Purpose of investigation and purpose of evaluation of patient with kidney problems. It is general evaluation of health. It is diagnosis of disease or disorders of the kidney or urinary tract. It is diagnosis or other systemic diseases that affect kidney function. Monitoring of patients with diabetes, and screening for drug toxicity, like a sulfanilamide or aminoglycosides. History taking goes with gathering of information, patient's narrative, biomedical perspective, psychological perspective, and context. And reminding with anatomy and topographical anatomy of kidneys. You remember position of kidneys and structure of kidneys and structure of urinary system in general. The position is important to remember before investigation of patient. It is palpation and percussion of kidney. One more time, anatomical position or kidney skeletotopy. In anterior view and posterior view, I remind you that kidney is placed more dorsal, more posteriorly, and it a little bit lower than ribs. And methodic of palpation of kidneys. Not in all patients it is possible to palpate kidney. In obese patient, in hyperstenic patient, in patient with ascites or significant generalized edema, it is difficult to find kidney. But in most patients you can palpate kidney. Technique of kidney palpation look like on this picture. Yes, patient lying supine, and it is bimanual. One arm we put under the back in a side when we palpate kidney, and with second arm we start palpation of kidney. That's why we name it bimanual. You try to evaluate kidney between your arms. And kidney pain localization according to anatomic position. It will be localization of pain. Usually it is a back pain. According to to affected kidney, it can be one side or can be bilateral. And kidney pain we can check with symptom with small pushing on the place, one side, another side. When kidney is affected, when is present some inflammation, some inflammatory disorders, this maneuver will be very painful for the patients with irradiation. Clinical examination of patient. In a general inspection, we can find with general state of health. It is fatigue, lethargy, diminished alertness, skin pallor, yellow-gray skin, excoriations, changes in turgor, bruises, texture. It can be rough or dry skin. In the mouth, it is possible for possible stomatitis and ammonia breath. Face and extremities. It is generalized and peripheral edema, bladder distension, masses, enlarged kidney. In abdomen, it will be abdominal contour for midline mass in lower abdomen or unilateral mass. By the weight, it typical weight gain secondary to edema, weight loss and muscle wasting in renal failure. During percussion, palpation and auscultation. Percussion of kidney can detect areas and tenderness of costovertebral test. Palpation, we can check contour, size and tenderness of kidney. Presence of tenderness and pain indicates a kidney infection or polycystic kidney disease. Percussion of bladder. It performed in area over the bladder 5 centimeters above the symphysis pubis and detect the difference in sounds. Percussion towards the base of the bladder. Ureteral meatus. Inspection for swelling, discharge and inflammation. Auscultation. First of all, we auscultate abdominal aorta and renal arteries. They are auscultated for bruits, which indicate impaired blood flow of the kidneys. Additional tests, laboratory examination. In the blood, we check serum creatinine. Normally, it have to be from 0.5 to 1.2 milligrams per deciliter. Blood urea nitrogen from 10 to 20 milligrams per deciliter. and blood urinary nitrogen to creatinine ratio, relation between them have to be from 12.2 to 20 to 2 mass. Urine tests. We do simple urine analysis, urine for culture and sensitivity. It is composite urine collection, most often needed during 24 hours, for example, for checking proteinuria. It is creatinine clearance test. It's used to estimate glomerular filtration rate. It is urine electrolytes and osmolarity, for example. We do it for as for plasma as for urine. Glomerular filtration rate. It is one of the most important indexes, one of the most important tests for renal function. It is a test how much the kidneys are filtrating, test for its function. In normal, it is about 100 milliliters per minute. This means that kidneys are removing all the creatinine found in 100 milliliters of blood every minute. Measure GFR. It is injecting of tiny amount of radioactive substance and measuring how quickly it disappears from the blood or appears in the urine is used to calculate GFR. It is a direct method of checking GFR. And it can be estimated GFR. We have for routine clinic more simple and more useful test for checking of GFR. We can calculate it by the formula from creatinine level and other information about this patient. And we can receive two signs. It is GFR or estimated GFR and creatinine clearance. Estimated GFR, it is using blood test, age, sex, and sometimes other information to estimate the GFR from modification of diet and renal disease. It is a name of formula, or shortly MDRD. This isn't as good as measuring it, but is much simpler and requires just one blood test. It is largely less invasive, less long, and much more cheap test than direct checking of GFR. Creatinine clearance. It is blood creatinine measurements by collecting urine for 24 hours and measuring how much creatinine is in the urine at the same time as finding out how much is in the blood. If any urine produced during the 24 hours is not collected, the result will be not accurate. It is understandable. Okay, what is the formula? Formula for estimated glomerular filtration rate, or eGFR. I told you that it is MDRD, or modification of diet in renal disease, and you see formula on the slide. And the most useful formula for clearance, creatinine clearance, it is Cockcroft-Gault equation. We use it very often in clinic too. The formula you can see too. You can do it with your calculator, but today it is possible this automatic formula on smartphone, online, and etc. That's why usually it is very quickly after biochemical analysis you receive level of serum creatinine, and according to it and other data of patients like age, race, gender, and body weight, you can receive creatinine clearance or eGFR. And according to eGFR, I told you that it is a main sign of kidney function. We can divide chronic kidney disease on stages. Chronic kidney disease can be 5 stages and several sub-stages, and their changes according to level of eGFR. If GFR is normal, more than 90 milliliters per minute, but it presents some symptoms of damage or laboratory or urinary syndrome, for example, laboratory, or present some symptoms, present some changes in visualization, but eGFR normal, it is chronic kidney disease stage 1. If eGFR a little bit decreased and from 60 to 89, it is stage 2, it is mild decrease in GFR. Chronic kidney disease stage 3, it is moderate decreased GFR and it is subdivided on two substages. The 3A, it is from 45 to 59 and 3B from 30 to 44. Stage 4 of chronic kidney disease, it is severe decrease in GFR. It goes with a 15 to 29 milliliters per minute for eGFR. And stage 5, when it goes kidney failure with eGFR less than 15, and it has substage 5D when GFR less than 10, it is emergent indication for dialysis. Okay, Uri Analysis. It starts from macroscopic examination, and here you see an example of different specimens of urine. And first change that we can check, it is color, macroscopic change, color of urine. Collection of urine specimen. Most common, we use first weighted morning. After 8 hours of sleep, we collect urine from the patient. For emergency, we can use random collection. And for urine culture, we ask patient to collect urine after clean catch and take the midstream portion. Urine optimally have to be examined within 1 hour in laboratory. It is important thing. Urine specimen examination can be physical with checking for appearance, volume, and specific gravity. It is chemical examination, microscopic examination, and checking urine for culture and sensitivity. By color, it can be normal, pale, or dark yellow, like urochrome. Abnormal, due to some drugs that can cause color changes. It can be red urine, most often due to hematuria, hemoglobinuria, myoglobinuria, or pseudohematuria. I later said a little bit more about it. It can be yellow-brown or green-brown urine due to bilirubin, for example, in obstructive jaundice. By the clarity, urine can be normal, it is clear urine, or cloudy urine, it's usually abnormal. Cloudy, it can be due to crystals or non-pathologic salts, due to phosphate, carbonate in alkaline urine. It is uric acid in acid urine. Various cellular elements like leukocytes, red blood cells, epithelial cells, etc. Okay, if it is red urine, I told you that most often it caused by hematuria. It can be microscopic when we can't see it by our eyes. Microscopic hematuria, urinary tract, usually due to urinary tract source. Urethra or bladder, it can be from prostate or ureter or kidney. And non-urinary tract source from the vagina, anus, or rectum. We have such term like pseudohematuria. It caused by myoglobinuria, hemoglobinuria, phenolphthalein laxatives, phenothiazines, porphyria, using of rifampin, pyridium, due to bilirubin anemia, using of phenytoin, pyridium, due to red diaper syndrome, foods, for example, beets, blackberries, rhubarb. All these cases, it is pseudohematuria when we see by eyes that urine is red, but it's not due to erythrocytes. Causes of asymptomatic gross hematuria. Most often it is acute cystitis, bladder cancer, benign prostatic hyperplasia, nephrolithiasis, benign essential hematuria, prostatitis, renal cancer, pyelonephritis, prostate cancer, urethral stricture. By the volume, normal adult average of urine during 24 hours, it is from 400 till 2000 milliliters. Increased average we name polyurea. It is more than 2 liters per day. It can be physiological, for example, increased water intake due to some drugs, diuretics, and using of intravenous solutions. And it can be pathological polyurea. A lot of causes can lead to pathologic polyurea. Most often of them it is chronic kidney disease, diabetes mellitus, and diabetes insipidus. Decreased average we name oliguria. Oliguria, it is volume of urine less than 400 milliliters per day. And when it's less than 100 milliliters per day, we name it anuria. Okay, changes of urine volume can be pre-renal, for example, due to hemorrhage, dehydration, or congestive heart failure. Due to renal parenchymal disease, like in acute tubular necrosis or chronic renal failure. Or it can be due to post-renal causes, and here most often it is obstruction of urinary tract, maybe stones, or for example carcinoma. Changes in specific gravity. Density of the urine compares to density of urine of the density of water. What it means, what is specific gravity. Normal average in adults is from 0.001 to 0.04. Increased specific gravity typical for dehydration, fever, vomiting, diarrhea, diabetes mellitus, overglycosuria, congestive heart failure, syndrome of inappropriate antidiuretic hormone secretion, or adrenal insufficiency. And decreased specific gravity typical for decreased urine volume and increased specific gravity, and in diabetes insipidus when urine volume increased and specific gravity is decreased. In chemical examination, we usually check urine pH. Normal pH of urine from 5 to 9. It depends on diet. Increased, we name it alkaline urine. It can be due to drugs, for example, sodium bicarbonate, classic renal tubular acidosis, and it can be alkalosis, general alkalosis metabolic or respiratory. And decreased urine pH or acid urine can be due to drug using too, like ammonium chloride, and general acidosis like metabolic or respiratory acidosis. We check usually level of proteins. It can be normal protein less than 150 milligrams per 24 hours. Increase of proteins more than 150 milligrams per day, we name proteinuria. You remember it from Nephrotic Syndrome part. Heavy proteinuria more than 4 grams per day. Moderate from 1 to 4 grams per day, and minimal proteinuria less than 1 gram per day. And we have, you remember, specific types of albuminuria, like microalbuminuria. Yes, it is specific proteinuria. We name it microalbuminuria when it contains from 30 to 300 milligrams per day. It can be glomerular due to glomerular disease damage glomerular basement membrane, but tubular function is normal. Most often it is selective proteinuria with heavy proteinuria, like in acute glomerulonephritis. And it can be not glomerular, it can be tubular. Tubular can be in renal tubular disease damage, tubular function, but not glomerular is normal. And moderate proteinuria, like pyelonephritis, overflow, functional, extrarenal. In chemical examination, we check for level of glucose. Normally it is negative, can be positive in diabetes mellitus, Cushing's syndrome, renal tubular dysfunction. We check for ketones, normally negative, ketonuria can be in diabetic patient, in non-diabetic patient, in hyperemesis of pregnancy, and patients with vomiting or diarrhea, especially very specific for children. In chemical examination, we check for occult blood, normally it is negative, bilirubin, urobilinogen, normally negative too, nitrates, normally negative, positive in presence of bacteria, and leukocyte esterase can be present in bacterial infection, fungal, parasitic, moreover in tumors and nephritis. Here you see examples of microscopic changes when we can find red blood cells in different pictures, white blood cells, epithelial cells, bacteria like in blue picture, and last picture some casts. They can be cylindrical molds, indicate damage of glomerular basement membrane or tubule. And we see the first picture, it is example of bacterial investigation for culture and sensitivity. It looks like on the first left picture. Instrumental examination. We can visualize urinary system and kidneys in several methods. First, the most useful, it is ultrasonography. Usually we use B-mode scan, Doppler floor examination of renal vessels, or duplex ultrasound scanning. Moreover, we can use radiographic examination with kidneys, ureter, bladder, X-ray, intravenous urography, computer tomography, cystography, and cystoureterography. And we can use other diagnostic tests like renal arteriography or angiography, renal biopsy, renography like kidney scan, and magnetic resonance imaging or MRI. Here you see examples of B-mode and lower M-mode of ultrasonography of kidneys with Doppler mechanism that let us check the blood flow in urinary flow in the urine tract. Here is a picture with renal arteriography. It is X-ray methods when we inject IV contrast. And here you see by the contrast visualization of abdominal aorta and renal arteries. And here it is a good view of renal artery stenosis. You see it is both sides but more significant right side. Here urography, it is the same, nearly the same, it is X-ray method with contrast, but here contrast injected not IV, it put it retrogradely in urinary tract. It injected from the ureter and visualize all ureteral tract. And here you see an example. It is simple X-ray without contrasting with visualization of huge stone. Not all stones are X-ray positive. Some stones we can see just on ultrasound. Some stones we can see just on X-ray. Here X-ray positive stones. It's very visible and you see such a huge bladder stone. And you see the same stone after the surgical operation. CT scan. Here you see an example of cystic diseases of kidney, and both and right and left, especially left side, you see that structure of kidney is very polycystic. One more time, example of MRI with gonadal dysgenesis. It is MRI of child, and due to this gonadal dysgenesis, it is obstruction of urinary tract. And PET, positron emission tomography. It is a very good method that help us visualize the S structure and S checking function and internal structure of kidney. Laparoscopic renal biopsy. A lot of cases when we can't put correct diagnosis and say about morphological changes of kidneys, what exact disease lead to these symptoms. And in a lot of cases it is not enough just laboratory tests, visualization, instrumental test. A lot of patients need biopsy, and usually to do like here, laparoscopic, and on the picture you see methodic, that with catheter with we go to the kidney, under the endoscopic control take the piece of kidney tissue to microscopic investigation. And here is the comparison of plain radiography. It is simple X-ray with abdominal CT scan. And you see on first picture that it presents something by the white arrows and a black arrow, some structure, but we are not sure what is that. What is the structure says us about. But on CT scan, second picture, we see that it is widened kidney and place of obstruction. It is hydronephrosis. Okay, and let's discuss the main diseases, the spectrum of urinary system diseases. What the main diseases can lead to all these syndromes and symptoms that we discussed during today's lecture. First of all, it can be congenital abnormalities, it can be interstitial nephritis, it can be glomerulonephritis, it can be cystic kidney disease, renal vascular disease, it can be nephrotic syndrome, renal failure, infections of the urinary tract, obstruction of urinary tract calculi and nephrocalcinosis, malignancy of urinary tract. Most often it is cancer of bladder or incontinence. And last slide for today, it is urinary system diseases symptoms. Let's in general discuss what symptoms can be in general for urinary system diseases. It can be pain, it can be proteinuria, it can be azotemia leading to uremia, hematuria, urinary casts, hypertension, oliguria or anuria, edema, polyurea, renal uretary colic, dysuria, renal failure, general symptoms of abnormal renal function. It was the main things for today. It is very shortly about urinary tract and kidneys, main signs and symptoms and syndromes for today. If you need more information, if you have questions and comments, as usual, I'm waiting for discussion on our Facebook page, or I'm waiting for your feedback in the comments under this video. And as usual, I'm asking you to leave all students who are listening my lecture the name and number of group in comments under this video on YouTube. For today, that's all. Goodbye and see you into